Welcome to CSAP 18 Audio Companion. Today I am pleased to have Dr. Jennifer Singh as my guest CSAP author. Jen, could you offer our listening audience a little information about yourself, including where your practice is located and how you spend most of your time in the practice of surgery?
Thank you. I am very pleased to be here with you. I am a breast surgical oncologist with City of Hope National Medical Center in Southern California. I serve as the medical director of breast surgery at City of Hope, Orange County.
Has it been raining down there lately?
Raining quite a bit in California with the recent storms, but today is bright and sunny.
Okay.
It's back to usual weather.
Well, anyway, thank you very much for that information. And I have asked you to participate in our discussion today regarding breast topics that are found in CSAP 18. So let's get right at it. So I have reviewed a few topics related to benign breast problems with your breast colleagues on CSAP Audio Companion already, but one topic I have not broached is granulomatous mastitis. First, is there some unique characteristics about this diagnosis that we should be aware of?
Yes, granulomatous mastitis, it's considered a chronic but benign inflammatory condition of the breast. The presence of non-caseating granulomas on pathology can be very suggestive of this diagnosis, but it's not required. It tends to present as a palpable mass with inflammatory features, often mistaken for a breast abscess or infection or even breast cancer. And it tends to occur a lot more commonly in our Hispanic population and also our women and men of Asian heritage.
So you mentioned that it's not an infection, but it seems to also be associated with foreign bodies in the breast. Is that correct?
Yes. The most common triggers can be a foreign body, such as a nipple ring or some other trauma to the breast. And that's considered to cause an inflammatory cascade to occur that prompts this formation of these non-caseating granulomas. So that really can present as a breast mass and cause surrounding inflammation of the breast tissue that looks very much like mastitis.
Is this a risk factor for breast cancer or not?
It's not considered per se a risk factor for breast cancer, but the chronic inflammation and the need for biopsies, those have been shown in breast cancer literature to be a risk factor when someone's had chronic trauma or other issues of the breast that causes inflammation. So it does prompt us to really diligently screen these patients for breast cancer in the future. It's not considered a direct relation, but something we need to keep an eye on.
Okay. And if I remember correctly, this becomes a vexing problem for patient and surgeon regarding management. So how do you manage a patient who comes to you and you make the diagnosis of granulomatous mastitis?
Yeah, so it can be very vexing, very confusing as an initial presentation too. Common things being common, we do need to make sure that there isn't an ongoing infection or an acute infection that's occurred for the patient. Typically, a culture of any fluid that's draining is very helpful. Oftentimes we see only just white blood cells, no bacteria, especially if someone's not been on antibiotics. That's actually very helpful to really ascertain what is going on. In addition, if it's a breast mass, first and foremost, we do still need to rule out that someone doesn't have an underlying malignancy or breast cancer or something more suspicious going on as well. Once those are ruled out, a pathologic biopsy can be very helpful to rule out that unconcern about cancer, but also rule in if there's this presentation of more of an inflammatory process on pathology review or these non-caseating granulomas that can help us direct the patient in the right direction for management.
Let me ask you about one of the suggestions in CSAP 18, which I do not remember seeing before. I've seen steroids being used, non-steroidals being used, but there's a statement about methotrexate potentially being helpful. Is that something that would be used in this condition?
Yeah, so initially, management of symptoms is the most helpful for these patients. Oral, topical, or even injectable steroids can be very beneficial. But in the very refractory cases, higher levels of immunosuppression, including methotrexate and other biologics, have been used successfully in treatment of this condition.
Well, let's move on, and I'd like to talk about high-risk lesions. High risk meaning they're high risk for future development of cancer. And there's a number of questions that I'd like to review with you for our listeners and discuss the risk and what to do with them in a given patient. Now, we can do this, I think, two ways, and I'll give you your choice. And I can give you a few, or you can discuss them in any order that you wish. So how would you like to do it?
If you want to name off a benign process or a high-risk process, either way.
All right. Well, let's talk about sclerosing adenosis.
All right. That sounds good. So sclerosing adenosis, it is considered one of the benign conditions that we see as breast surgeons. It can present as a scar-like fibrous tissue and an area called a focal asymmetry on mammogram. This can very much mimic an early breast cancer on imaging. So a biopsy is often needed to tell the difference between sclerosing adenosis and breast cancer. Once this diagnosis is made, it is considered benign. An excisional biopsy is not required. It's not an obligate precursor to cancer. However, it can slightly increase the risk of a woman developing breast cancer over the course of their lifetime, as it's on the spectrum of fibrocystic changes of the breast.
I always like to remind myself when we're talking about imaging and biopsy, what you're really looking for here then is concordance between what the imaging suggests and the biopsy shows. Is that correct?
Absolutely so. In any of these presentations on pathology, crucial that the radiologist and pathologist thinks there is a concordance on any of the reviewed tissue samples.
Okay. How about stromal fibrosis?
So stromal fibrosis similarly can present as an imaging abnormality that is called and can bring a patient in for further workup. When it is seen on pathology diagnosis, again, does not require an excisional biopsy for further underlying risk. It is considered a benign process as long as there's radiologic pathologic concordance. A lot of times, though, it can present as a palpable mass. So in these instances, definitely going down the pathway of appropriate imaging and tissue diagnosis is very helpful to rule out any concerns that the patient may have.
Okay. How about atypical ductal hyperplasia, or ADH?
So atypical ductal hyperplasia, now this is pathologic diagnosis. We oftentimes do recommend a surgical excision. It is considered on the spectrum of atypia that can have an underlying malignancy when you excise some of the surrounding tissue. Independent predictors of upgrade tend to be when a woman is of older age, when they have a family history, if there's associated microcalcifications, and a larger size of abnormality on imaging as well. Large gauge needles, such as 10 gauge needles and above, and adequate sampling can be very helpful to really adequately capture a good sample of this area that's abnormal on the imaging.
And when we talk about many of these lesions, the other statement we make is they get upgraded and with the biopsy, and the upgrade usually means that there is a foci of cancer or at least in situ cancer. Is that the usual explanation of upgrade?
Yes, great clarification question. Upgrade is usually what we mention in terms of why a patient needs an excisional biopsy of an area of atypical ductal hyperplasia. But this can be an upgrade to an invasive or a low-grade ductal carcinoma in situ. Upgrade to invasive cancer tends to be a very low percentage of the upgrade diagnoses. More commonly, an upgrade is to low-grade or intermediate-grade ductal carcinoma in situ.
Thank you for helping me at all. I always need help. So anyway, how about another one? How about atypical lobular hyperplasia?
Yeah, so historically, we used to always routinely excise atypical lobular hyperplasia, similarly to ADH. Nowadays, we know with more current studies that the absolute risk of upgrade when we do excisional biopsies on atypical lobular hyperplasia is low enough that we can typically follow these patients as long as we believe the patient had adequate sampling of the area of abnormality on imaging as it's more commonly presented, and also that there's radiologic pathologic concordance again. As long as these are in place, a patient can be safely followed, usually with a shorter term interval imaging of that side.
It's amazing as surgeons how many times we go out of our way to avoid what we like to do, which is actually do surgery. But I remember this is one that we used to do all the time, and now, as you say, we can observe some people. So how about lobular carcinoma in situ?
Lobular carcinoma in situ has evolved a bit over time in terms of what we recommend as well. Easier to think about in terms of classifying it as either classic or pleomorphic lobular carcinoma in situ. Pleomorphic lobular carcinoma in situ is still considered a much more aggressive form of LCIS. In the staging, the AJCC 8th edition staging for breast cancer, it was almost considered still stage 0. There was quite a bit of debate. And so at this point, if it is a presentation of pleomorphic LCIS on core needle biopsy, we do recommend an excisional biopsy, almost treating it similarly to DCIS, as the upgrade rate to carcinoma and invasive carcinoma is 50% or higher in a lot of studies. However, classic LCIS is a little bit different. It's considered more of a benign process. When there's radiologic pathologic concordance of an area found just on screening mammogram to be abnormal and biopsy to be classic LCIS, these patients can be observed if they don't have any other high-risk factors, such as family history, older age, hormonal use. So those are instances that we do a very good risk assessment of the patient and a really shared decision making of a good risk benefit of whether a patient should continue to be observed on a short-term basis versus have this area excised. Any LCIS that presents as a mass, though, does need to be excised, whether it's biopsy to be classic or pleomorphic, as LCIS is considered to traditionally not be a mass-forming process.
Let me ask you regarding the pathology report. Do the pathologists use classic and pleomorphic the same way that the breast literature uses them?
They do try to report that out, and anytime that they don't, I encourage any surgeon to ask their pathologist for a more detailed review. Is this a classic or a pleomorphic LCIS? Are they seeing calcifications if there were some seen on imaging? Are there any suggestions of other areas of atypia that may tip your hand to suggest a patient should have an excisional biopsy?
Okay. How about another one? Flat epithelial atypia.
Yeah, so atypia in the name makes it very confusing for our patients, unfortunately. But even with that name aside, it actually is not considered a pre-malignant process or a process that increases future breast cancer risk. So at this point, a routine excision is not indicated unless it's associated with other more concerning areas of atypia like atypical ductal hyperplasia or lobular carcinoma in situ.
Well, it confuses me too, so I can understand how the patients get confused.
Yes, definitely so.
And another one would be radial scar.
Radial scar, yes, can present similarly to sclerosing adenosis, that it looks very abnormal on screening imaging and even diagnostic imaging. Instead of focal asymmetry, it tends to present more as a spiculated mass or architectural distortion instead. We know that smaller lesions, less than 1 centimeter in size on imaging, have a lower upgrade rate than bigger areas of abnormality that are 1 centimeter or greater. When less than 1 centimeter, we tend to refer to these areas as radial scars. Larger lesions, 1 centimeter or greater, tend to be referred to as complex sclerosing lesions instead. And the surgical upgrade rate can be as high as 40%, especially when you get into areas of abnormalities 1 centimeter or higher. Oftentimes, these are recommended for excision in weighing risks and benefits to the patient and also accounting for their lifetime potential risk for breast cancer as well.
Another lesion that just amazes me because I've always thought it is always benign, and I think this is an upgrade issue again, but what about papillary lesions?
Yes, papillary lesions. The traditional presentation we think about in surgical training is someone coming in with bloody nipple discharge, and we find a small lump in the nipple areolar complex area, retroareolar area that's biopsied to be a papilloma, and we discuss removing the papilloma to rule out an area of underlying carcinoma triggering that symptom presentation. However, a lot of times we see papillomas come up in just routine imaging screening for patients. They can be a little bit bigger in size and associated with the central ducts prompting nipple discharge, but there can be also more peripheral papillomas that are presenting as more nodules or small lumps on mammogram or ultrasound. Upgrade rates can be as high as 35%. Kaiser actually did a great study where they were looking at risk factors for when a patient is more likely to be upgraded, and that tends to be women who are older age. Again, we tend to say about 50 to 55 or older, size of the area greater than 1 centimeter, family history of cancer, and if there's been a history of atypical biopsies in the past for the patient.
Okay, have I missed any that we should talk about?
I think that's a pretty good list, Dr. Weigel.
Okay, all right. We'll leave it there for today then. Okay. All right, let's move on to the topic of genetic testing. And once again, I need some help here. So besides a clear family history of a genetic relationship with the family, are there really strict criteria that make you think you should send your patient for genetic testing?
Currently, the American Society of Breast Surgeons, we recommend that all breast cancer patients consider genetic testing. Now, whether they should or not, oftentimes is a really good individual patient discussion for that. Sometimes it can affect the extent of surgery someone may want to undergo, or thinking about further surveillance for them in the future. And also, a lot of times patients come in very concerned about family members who may be at risk. And this can help in understanding their risk and how closely they need to be plugged in for screening at a younger age. For a patient who does not have a diagnosis of breast cancer, this is when a really good individual risk assessment is helpful. Using our Gale and Tyrer-Cuzick risk models, it's a oftentimes very simple, quick risk calculation that you can bring up these risk calculators just by searching Google. It takes a couple minutes to plug in a woman's personal risk factors, such as the times they've been pregnant, if they breastfed, age of menarche, menopause, whether they took any additional hormones over their course of their lifetime. And the Tyrer-Cuzick model also accounts for extended family members as well. And this is very helpful, especially for a patient who is very proactive on their screening. I tend to calculate these individual lifetime risks to make a judgment of whether they may benefit from genetic testing to calculate a polygenic risk score. That's a biologic score to help inform lifetime risk of breast cancer, and also to meet that 20% lifetime risk threshold that most insurance companies want to justify a breast MRI as part of a woman's screening.
So that 20%, it seems to crop up all over the place. So that would be somebody with a risk greater than 20% that, especially if they were concerned about family members, that you would involve genetic screening when you're talking about how you're going to manage the patient. Fair?
Yes, these are definitely the patients we would love to refer on. Those who are a little bit higher than population risk, which we consider to be 12%, 1 in 8 women. Anywhere between 12 to 20% we consider intermediate risk, and those patients are often very still closely screened on an annual basis, and can choose to end up wanting to have genetics done as well. But the population I concentrate more heavily on are those who are 20% and higher in lifetime risk.
Okay, now I must say I have watched this evolve over the CSAP editions when we used to talk about maybe one gene, and now we're talking about many genes that are associated with breast cancer. So it's a moving target, but can you give us some idea when I send a patient for genetic testing, what does that entail?
Yes, it's an informative process still, first and foremost. It's considered very personal, very protected information for all patients. So a counseling session is initially held by the genetic counselor or genetic physician, going through the risks and benefits of genetic screening, really making sure that a patient has an understanding, feel like they are informed going through. And it is a consent that they undergo before they are provided with testing materials. Testing tends to be a blood sample or a saliva kit, and can be scheduled at the time of the counseling visit, or they can perform that shortly afterwards.
Let me ask you, is this testing readily available? I realize in Southern California there are probably numerous opportunities for this, but what about some of our rural surgeons? Is it possible to do this testing remotely or virtually today?
Yes, and oftentimes our genetic counselors at a lot of the major centers offer telemedicine visits to patients who in the surrounding locations, as well as more remotely as well. And so during the pandemic, especially City of Hope, we converted all of our genetic testing counseling sessions to remote virtual video sessions. And patients were mailed saliva kits that then they were provided instructions with on directly how to return. And a follow-up video session was then held with patients to review results and making sure that patients have the appropriate surveillance recommendations moving forward as well. And that has continued now. I think that's one of the positives that's come out of our switch to the virtual environment, that I think there has been expanded access of this very important aspect of things. And oftentimes surgeons who are very interested in learning how to do the counseling, making sure their office is equipped. A lot of the major societies, American College of Surgeons, American Society of Breast Surgeons, has information and also educational sessions on how to set up your own process.
As far as the individual patient go, I realize there's many variations of this depending upon what the genetic results show, but eventually this is going to change either surveillance or surgery in some fashion. Is that a fair statement if it's a positive risk finding within the genetic testing?
It can change a patient's decision for surgery. Someone may be more interested in prophylactic surgery, risk reduction prophylactic surgery, or consider therapeutic mastectomy when they may be breast conservation eligible, and also contralateral prophylactic surgery. However, even the most highest risk mutation carriers, we consider those with the BRCA1 and 2 germline gene mutations, can be safely screened in the future. Patients are recommended for yearly mammograms starting at age 30 if they are known to be BRCA1, 2 mutation carriers, and MRIs even as young as age 25. For someone who is very proactive in their screening, has access to a physician's office to undergo these studies and have a yearly clinical exam, it's considered very safe to watch patients with these mutations.
Let's take another topic and let's talk about some micrometastases in your axilla discovered during a lumpectomy and sentinel lymph node biopsy. Let's say you got 2 nodes with 1 millimeter area of carcinoma. Where do we go from there these days?
So the American College of Surgeons Oncology Group, ACOSOC Z11 trial, was a landmark trial for us in the breast cancer world. It was published in 2011, and it demonstrated that patients with early breast cancers, clinical T1 or T2 invasive cancers, who were clinically node negative to start on presentation, but found on sentinel lymph node biopsy to have 1 to 2 sentinel lymph node metastasis, they can be safely managed without undergoing an axillary lymph node dissection. So those patients, because they are breast conservation patients, did get adjuvant whole breast radiation, and the tangents from the whole breast radiation were sufficient to cover the axillary field enough to give adequate local control. So patients who underwent just adjuvant radiation and did not go forward with an axillary lymph node dissection, they had equivalent outcomes in terms of survival. But importantly, they had decreased rates of very morbid side effects such as lymphedema that can occur with increased axillary surgery and radiation on top of that.
Yeah, we're going to talk about lymphedema here in a little bit, but there's another term that I'd like you to help us with, and that is targeted axillary dissection. Can you explain that a little bit?
So targeted axillary dissection comes up as a term not in those patients who are going for upfront surgery. It's more relevant for patients who are clinically node positive to start and had some form of neoadjuvant systemic therapy. At the time of conclusion of their neoadjuvant systemic therapy, we feel that they've had a robust enough clinical response in their axilla. Their lymph node should have turned negative on examination as well as imaging. Then instead of going forward and committing a patient to needing an axillary lymph node dissection, a completion axillary lymph node dissection for what we knew was node positive disease, we're giving them the benefit of the doubt now. So we go in and remove that lymph node if we can, and then also do a sentinel lymph node biopsy. With any of those lymph nodes, if they're negative, then we know it gives us a sense that the basin has had great systemic therapy control, and we can spare the patient axillary lymph node dissection. But those patients do still typically go to adjuvant radiation right now. There is a study, NSABP 51, and that is pending results to demonstrate whether those patients can forego adjuvant radiation. But for patients who had a targeted axillary dissection on final path or still node negative, they are still referred to adjuvant radiation at this point.
Well, let's take another topic that seems to gather a lot of discussion every time it's brought up, and that's triple negative breast cancer. So once you have a patient where your biopsy comes back and we've got triple negative results, does her workup differ at that time?
I like to think these patients are, where are they in terms of their stage at presentation? Is this a patient who has a triple negative breast cancer who's a surgery upfront patient, or one that I would refer to neoadjuvant systemic therapy first? So if planning upfront surgery, this is a patient who typically has a cancer that's 2 centimeters or smaller, so clinical T1, and node negative. I often find a breast MRI can be helpful in additional workup, especially if someone has denser breast tissue, to confirm extent of disease. But for someone whose cancer is very clearly delineated on existing imaging, on examination, they may need no further workup other than going straight to surgery for excision of the area via breast conservation therapy or mastectomy, and doing a sentinel lymph node biopsy if they were clinically node negative. Now, if a patient has a larger size cancer, it's one that's clinical T2, so greater than 2 centimeters or node negative, they're considered higher risk. These patients really benefit from neoadjuvant systemic therapy up front, as they are incredibly high risk to have already nodal disease at initial presentation or even systemic disease as well. For these patients, then, a breast MRI can be considered part of the initial workup and is thought to be a gold standard of following a patient through neoadjuvant systemic therapy when we do an exam by MRI pre and after neoadjuvant systemic therapy. And a patient who has stage 3 disease, so a patient with a greater than 5 centimeter tumor or extensive nodal disease, should really have systemic staging too as part of their workup, which tends to be a PET scan or a CT bone scan in combination for these patients.
In that second patient where you're doing neoadjuvant chemotherapy, is that patient going to come back, and would they ever be a candidate for breast conservation surgery?
Yes, that's one of the benefits of neoadjuvant systemic therapy. Our therapy regimens can convert a patient with more extensive volume of disease to someone who becomes breast conservation eligible. Someone may also have started breast conservation eligible, someone with a smaller breast cancer size in relation to their breast volume, but may needed systemic therapy up front due to nodal disease. And so that still holds that the similar principles as we would decide whether someone's breast conservation eligible for upfront surgery still holds in the neoadjuvant paradigm.
Well, let's take another topic, and that would be adjuvant chemotherapy and endocrine therapy, which obviously is commonly used post-op. And so actually CSAP 18 has many more questions regarding endocrine compared to chemotherapy, but let's start with adjuvant chemotherapy. And we're seeing neoadjuvant and adjuvant chemotherapy being used more and more in various cancer, but in the breast cancer patient with early invasive ductal carcinoma, what's the decision that drives the use of adjuvant chemotherapy?
Yes, so someone with early invasive ductal carcinoma, we are often looking at their subtypes and whether they have features that would indicate higher biological risk. So that is the grading of the cancer. A grade 3 cancer, much more concerning. A higher Ki-67 if your pathology lab runs that, level 2. We know cancers that are HER2 positive, so 3+ by IHC or amplified by FISH, as well as patients that have a triple negative breast cancer. These are considered cancers that are higher biologic risk. So cancers that are 2 centimeters or greater, that often are sent for upfront systemic therapy. But any patient who has after surgery 5 millimeter or greater cancer that is HER2 positive, amplified, or triple negative should be offered adjuvant systemic therapy to reduce their risk of local and distant recurrence in the future.
Okay, so are these new scoring systems? Maybe I'm using the wrong new there, but certainly they've been around now for a little bit. Do they help us make that decision, like the Oncotype DX system?
Yes, very much so. So we know that patients that present as HER2 positive, amplified, or triple negative will automatically be recommended when they have a cancer that's 5 millimeters or greater. Smaller than that, it's often a good discussion. Now, what about that population that has hormone receptor positive cancer that's HER2 negative? So these are the patients that new genomic testing scores, such as Oncotype DX, is one of the more common ones that is used, or MammaPrint. They can help the decision. So the scoring systems stratify patients as either low, intermediate, or high risk in Oncotype, or low or high risk in MammaPrint. And this is very helpful because a patient who is low risk of cancer recurrence while on endocrine therapy, we do not think that they would benefit from receiving adjuvant systemic therapy or chemotherapy, is usually easier to say. However, someone who's high biologic risk on one of these scoring systems, they should be offered adjuvant chemotherapy, systemic therapy, to reduce their risk of future recurrence and also reduce their risk of mortality as well.
We've been talking about the breast lesion, but I'm going to assume that if the disease is node positive, adjuvant chemotherapy will always be used?
So not always. That's an area of evolution as well.
I set you up.
Yes, exactly. So patients who had traditionally that were thought to have 4 nodes or positive or more are considered patients who should automatically receive adjuvant chemotherapy. That tends to hold these days. However, we do know with new information that we get from Oncotype and MammaPrint in the node-positive patient population that sometimes a patient can present very aggressively clinically, but their biologic risk is low risk, which means that is a really good risk benefits discussion then with patients by medical oncologists of whether someone would want to undergo adjuvant systemic therapy for potentially some benefit, but maybe not quite as much benefit as someone whose tissue had demonstrated some higher biologic risk. So these patients can really benefit from thorough discussions based on these new information details that occur as well. In the hormone receptor positive population as well, a new adjuvant therapy we think about is also the CDK4/6 inhibitors. So a patient who's node positive with some other higher risk factors may be eligible for this newer class of medications for hormone receptor positive disease in the past when they would have been as well.
When we talk about adjuvant chemotherapy, what are we expecting the benefit to be with these drugs? Is it decreased local recurrence, decreased axillary recurrence, or is it decreased systemic disease?
It's all of it. Decreased local regional recurrence, decreased systemic recurrence, and also reducing mortality. Adjuvant chemotherapy traditionally is thought to reduce mortality by 25% or more.
And the complications from this therapy are not great, or are they acceptable, I guess?
Acceptable in terms of risk-benefit profile. I think oftentimes a baseline performance status health assessment is absolutely needed before recommending a patient for adjuvant systemic therapy, as there are side effects that can occur with any of these drugs. I think it's a balance between what we know can potentially reduce their risk of cancer coming back over the course of the rest of their lifetime versus the short-term toxicity of these drugs and hopefully no long-term toxicities as well.
Risk-benefit decision again.
Yes.
Happens every day for all of us. Okay. And I must ask you, because of an article I just read, and I'd never thought about it before, but as we use more neoadjuvant chemotherapy, is there any danger or, well, let me just say that the article concluded that adjuvant chemotherapy could be used safely after neoadjuvant chemotherapy. Any comments? Is that a clinical problem that you discuss on a routine basis with your patients?
No, I actually find that neoadjuvant chemotherapy, what it does is it tells us how well a patient will respond to this therapy, because we have their cancer still in the patient to monitor, to see what is happening in response to these drugs. We know that our surgery, what it does is it removes anything that's still active, and we understand better resistance patterns then to that neoadjuvant systemic therapy, so that our adjuvant systemic therapy can now better target those resistance areas that were not treated well enough in the neoadjuvant regimen as well. So I think they definitely go hand in hand. For a patient who does not have a pathologic complete response, we know that the second, third, fourth line adjuvant chemotherapy, systemic therapy medications are now absolutely crucial because it can continue to reduce the risk of recurrence and reduce the risk of mortality by making sure these patients receive these drugs appropriately.
Well, let's move on to endocrine therapy. And I think we kind of have an idea of which drugs for which patients, but how about the male patient with breast cancer, especially hormone receptor positive, which most of them are? What endocrine therapy do you use in that patient population?
So we go straight to tamoxifen for this patient population. We don't think about them in terms of pre-post menopausal status, clearly. Okay. But aromatase inhibitors, they do not suppress estradiol levels in men to the same extent they do in women. And so there is increased survival demonstrated when men are treated with tamoxifen versus aromatase inhibitor. For patients who cannot tolerate tamoxifen, a combination of a GnRH analog with an aromatase inhibitor is considered an acceptable alternative.
Maybe the hardest question, because it seems to be a moving target, is when you put a patient with DCIS on endocrine therapy, how long do you have to treat this patient now?
That's a great question. So usually we do so if a patient still has breast tissue in place. They had breast conservation. They still have their other breast. For patients who have bilateral mastectomies, final path only showed DCIS, no invasive carcinoma. Those patients are not recommended for adjuvant endocrine therapy. Now, those patients who are recommended for it, similar to patients who have invasive disease, we can run a breast cancer index test to see for these patients, how long they should potentially continue. We know the general guidelines is about 5 years if they can tolerate for additional risk reduction, 10 years for patients who may have some increased risk factors such as a strong family history or germline G mutation. But I think most of us have a lower threshold of having patients stop their endocrine therapy if they were DCIS without invasion of significant side effects.
And you mentioned the preventive aspect of endocrine therapy. Now, for one of those high-risk patients, like LCIS, are we using endocrine therapy as a method to decrease their chance of developing breast cancer?
Yeah, someone with a higher risk lesion like LCIS, atypical ductal hyperplasia, endocrine therapy can definitely be offered as part of their ongoing high-risk screening from there on out. It can be tamoxifen and aromatase inhibitor in similar doses we give for patients with a carcinoma diagnosis. Newer studies coming out of Italy have shown that a fraction of the dose of tamoxifen can be given with just as beneficial preventative results with the reduced risk of the significant side effects we think about with tamoxifen, like the uterine cancer risk and the thromboembolism risk too. So that has been a new go-to alternative, a low-dose tamoxifen regimen for prevention. Also, the preventative patients sometimes are switched to an analog of tamoxifen, raloxifene as well, with some good benefit.
Let's go and take that topic, lymphedema. But before I talk about that complication, you had an interesting question in CSAP 18 about shoulder motion after mastectomy. And I must say, this was new to me. So how often is this a problem?
More than we, I think, have used to recognize for patients, especially with more extensive breast surgery after mastectomy. Post-mastectomy range of motion limitation can definitely come up quite a bit for patients, especially in the context of axillary surgery, sentinel lymph node biopsy, or axillary lymph node dissection too. Especially as part of our post-operative instructions, we tend to restrict range of motion for these patients in the initial post-operative time frame while we're waiting for drains to dry up to be able to be removed, or having them be cautious of any incision. And that increased tightness, especially if someone may need radiation in the adjuvant setting, can come up in a significant fraction of women. So early range of motion has thought to be very beneficial, engaging OT, PT in a peri-op setting, having them have baseline consultations before surgery, even if there's someone that you are particularly concerned about, can be very beneficial. If someone is not improving with a trial of physical therapy, the patient may even benefit from an orthopedics consult to ensure that there's not some underlying pathology that was not recognized before your surgery.
And I was going to say, are there specific patient risk factors that you can almost predict that this decreased shoulder motion is going to happen?
I think definitely those patients with more extensive surgery, the patients who are receiving adjuvant radiation, patients who actually have received neoadjuvant systemic therapy are thought to be a little more at risk as well. Patients with baseline orthopedic arthritis issues are those considered higher risk. Patients with higher BMI can also, unfortunately, suffer some ongoing post-mastectomy pain issues. Similarly, patients who have baseline pain requirements, even taking a daily Advil is thought to increase the risk of post-mastectomy pain for whatever reason, headache, something more significant. Someone who has underlying psychological diagnoses, even mild depression, anxiety is thought to exacerbate the pain cascade in the postoperative setting and have these issues of limited range of motion become very exacerbated as well.
Let's discuss lymphedema a little bit. So we usually start the discussion with surgical principles that can help us avoid this complication or at least make it less likely. You want to review those principles for us so that we don't forget them?
I think the newest technique that most breast surgeons are employing these days is something called axillary reverse mapping. We have recognized through the great work by Dr. Klimberg that recognizing arm lymphatics is one of the keys to protecting arm lymphatics to prevent the increased risk of lymphedema. So this is a very simple technique. We inject blue dye, isosulfan instead of methylene blue. Methylene blue, as a reminder, can cause local necrosis. So we tend to use isosulfan blue that's injected in the medial arm of the ipsilateral side that you're doing the axillary surgery on. A couple minutes of massage allows for the travel of the blue dye into the axillary space. And having used this technique now numerous times, I tend to see the arm lymphatics come in laterally. That tends to be the area that needs really nice protection. So being careful of when you are planning your axillary incision, you're using that 2-finger breast from the axillary crease to oftentimes make your scar, but not going too laterally on a patient as well is very important, because oftentimes that lateral aspect is where by far a lot of lymphatics are coming in from the arm. So that has been very key, just by recognizing where the arm lymphatics are, trying to protect them if they are not part of your specimen, has significantly reduced lymphedema rates in a lot of the studies Dr. Klimberg and her group have published, and follow-up studies by other groups as well.
And in the patient who is getting neoadjuvant chemotherapy, is that a risk factor for developing lymphedema?
Yes, and originally it didn't seem to be the case, but now we know that chemotherapy, even a couple weeks later at the time of surgery, can increase capillary leak. And so this has actually been thought to increase the risk of lymphedema in these patients.
And what about adjuvant chemotherapy? Same thing?
Similar in concept, but hopefully the adjuvant chemotherapy is being applied a lot later than after healing from the initial surgery. So that would be wonderful.
Okay. And the treatment of lymphedema is usually non-surgical. Is that fair?
Usually non-surgical. Compression garments, working with therapy is absolutely crucial for this patient population. Especially when they're starting to even develop some of the initial suggestions of lymphedema. This can be elicited often by patients starting to say they're noticing a lot of tingling, a lot of odd sensations through the arm. That may be some suggestion that there's some mild subclinical lymphedema developing. And having these patients appropriately seen and managed by therapy is incredibly helpful. For very refractory cases of lymphedema, our plastic and reconstructive microvascular surgeons can offer different techniques to help. Lymphovenous bypass is one of the more common techniques that have arisen in the literature and in different surgical practice groups as a treatment for lymphedema, and some centers are even exploring it on a preventative basis, doing lymphovenous bypass at the time of the axillary lymph node dissection.
Yeah, those procedures have surfaced in CSAP, although mostly they've surfaced for the lower extremity lymphedema, but they are being applied in upper extremity lymphedema after breast cancer?
Yes, I would say not standard of care by any means. Centers that are doing it oftentimes have patients on study. There is an alliance study, in fact, looking at the axillary reverse mapping and looking at the outcomes of this patient and conscious of those who would eventually also get lymphovenous bypass as well. And I think in the next 5 years, we'll know a lot more about this as well. A higher level surgery, so a patient and a surgeon tend to need access to a microvascular surgeon, so not always readily available, but can be very helpful for patients who have refractory lymphedema to be referred on to our plastic and reconstructive colleagues.
Well, let's take another topic, and actually it's two topics. So two less common breast cancers are Paget and inflammatory. First of all, can I separate these two clinically, or can I recognize a patient with one or the other confidently by clinical presentation, signs, and symptoms?
Yeah, so Paget's is a very localized process around the nipple areolar complex. It presents with that eczematous sort of ulcerative look of the nipple areolar complex. I have actually seen some presentations that also are just a very retracted, very verrucous presentation to the nipple areolar complex, especially in comparison to the other side. I think that's absolutely key. When one nipple areolar complex doesn't look like the other, that Paget should be suspected, unless there's something the patient is telling you about their clinical history that suggests a different cause for that to occur. Now, inflammatory, this is when there's edematous, erythematous changes involving different aspects of the breast, not just the nipple areolar complex. It can be overtaking the lower pole, upper pole of the breast, the lateral pole of the breast. And so the classic definition of inflammatory breast cancer is when over a third of the breast is red and swollen, and especially the patient or you as someone following their exam is noticing rapid changes as well.
And in that Paget's disease, do you usually make the diagnosis by biopsy of the skin lesions?
I find it to be very helpful because there are cases of eczema of the nipple areolar complex. So in those cases, those patients tend to be managed with steroids and clearly do not need any underlying workup of anything more suspicious as well. But a nipple areolar complex skin biopsy can classically demonstrate those pagetoid cells on microscope, and that is very helpful to make this diagnosis when this may be the only clinically abnormal aspect of the patient's exam or imaging.
So if you find those cells in that biopsy and you image the breast, how often do you find a mass?
Yeah, so historically, just with mammogram ultrasound technology, especially before 3D tomosynthesis mammogram, there were cases where we would not find an underlying breast area. This may be because Paget's disease, in one of the etiology origin theories, was that it's a cancerous process that starts itself at the nipple areolar complex before it moves inward towards the breast. The other theory is that it's the opposite way. But if we're going by the first theory, then maybe there isn't an underlying breast cancer other than at that nipple areolar complex site. However, with tomosynthesis, 3D mammography, our increased experience with ultrasound, and also breast MRI, we often do find an underlying focus these days that should be biopsied. For those patients that we don't, then they would benefit at time of surgery with a central lumpectomy, excising the nipple areolar complex, or if a patient chooses to mastectomy, but they would be very nice breast conservation candidates then too.
So if you only have the Paget cells and you excise the nipple, is there ever a need to do sentinel lymph node biopsy on those individuals?
Yes, so at the time of surgery for Paget's, we consider Paget's to be on the spectrum of ductal carcinoma in situ. So in someone undergoing breast conservation and with a central lumpectomy, there is that ability to go back and use single or dual tracer to perform a sentinel lymph node biopsy. So I oftentimes will hold off on it, as Paget's on final path tends to most of the time come back with ductal carcinoma in situ. Of course, there are those instances with an upgraded invasion that all of us should counsel our patients that they may need a secondary surgery. But at this point, doing a routine sentinel lymph node biopsy for upfront DCIS diagnosis is thought to increase morbidity and has really fallen out of favor as part of the routine part of management.
So essentially, it sounds like when you have a Paget cell, you do your nipple excision, wait for the final path, and then treat the patient the same as if you would find DCIS or invasive ductal carcinoma?
Yes, very much so. So if they have breast conservation with a partial mastectomy or lumpectomy, they should be referred on for adjuvant radiation. As indicated. And then also if they have hormone receptor positive ductal carcinoma in situ, they can be offered risk reduction endocrine therapy as well.
Let me push you a little bit and say you just find Paget cells and there's no DCIS or invasive cancer. Are you finished?
You may be done then too. Very unusual, but you may be done.
Okay, all right. Okay, very unusual though. All right, I accept that. Let's move on to inflammatory then. And you kind of gave us a definition. But I have a question because I have seen it vacillate back and forth, and that is, doing a skin biopsy in a patient you think presents with inflammatory. Sometimes I see the answer as being, yes, we should do it. And sometimes I see it's not worthwhile. So where do you stand on this discussion or controversy, if it is?
I consider a skin punch biopsy to be something that rules in but does not rule out inflammatory breast cancer. So someone with a very concerning clinical presentation that you would say, I'm 99% sure just by looking at this breast, it's grossly swollen, very erythematous. They have really palpable lymphadenopathy, like huge mass on presentation, something you're very classically worried. I don't think a skin punch biopsy is necessary for you to absolutely be sure this is inflammatory breast cancer. They're meeting that clinical presentation definition of over a third of the breast is erythematous and edematous. I think the risk of you doing a skin punch biopsy, if you get a false negative, you may grossly undertreat a patient. Now, we have those patients who present, though, with extensive lymphadenopathy. So their lymphatics are very congested, and a patient can present with a lot of lower medial pole swelling, edema of their breast, in someone who presents with extensive lymphadenopathy. In those patients, you may, on exam, be questioning whether they really have an inflammatory presentation versus congestion of their lymphatics causing that downstream swelling. In those patients, I do find a skin punch biopsy to be helpful, and that can really help clarify, is this, it's usually someone that I think very likely does not have inflammatory, but has that erythema and edema in a localized area of the breast that I'm worried about. And I would do a punch biopsy at that part.
And you kind of alluded that there's new techniques of imaging now. So is this a patient who we're using advanced imaging to make a diagnosis of inflammatory?
So inflammatory, especially with that initial presentation, I think the visual impression on exam is key first and foremost. But doing the usual diagnostic imaging is critical to determine how extensive the disease is you're seeing under the surface. So the diagnostic mammogram, potentially with tomosynthesis, ultrasound, and also breast MRI. But these patients on presentation are staged are of a higher stage, so they should undergo systemic staging, actually first and foremost as well.
What if the imaging does not show a breast mass? What's your next step?
It can be quite unusual. I think then the skin punch biopsy, I think, is absolutely helpful to find some carcinoma cells to do some tumor markers on and biomarkers on. But especially if it's presenting as an inflammatory breast cancer, I think understanding that they may not have an underlying focus that we are worried about, but at the point that there's carcinoma invading the dermal lymphatics, they should still be treated as an inflammatory breast cancer patient.
And if the imaging shows a breast lesion, do you biopsy that as well if you are pretty convinced it's inflammatory breast cancer?
Oftentimes, if you didn't do a skin punch biopsy, then yes, for more of that tissue biomarker subtype testing, oftentimes that's absolutely helpful to really understand what neoadjuvant systemic therapy is appropriate for them. If there is more than one focus in a patient, that is also helpful to biopsy more than one area because there is heterogeneity in cancer presentations. And so that's important to understand which neoadjuvant regimen is appropriate to making sure that you're not missing one focus that's HER2 amplified and one isn't, for instance, is absolutely key.
So I think we're back almost where we started because we're talking now about neoadjuvant chemotherapy. And is that the first step in treatment of a patient with inflammatory breast cancer?
Yes, so still the paradigms that we have thought about for decades still holds for this population, since it's considered such an absolutely high-risk population. So neoadjuvant systemic therapy, neoadjuvant chemotherapy in patients who are triple-negative breast cancer patients. Nowadays, we actually give them neoadjuvant immunotherapy as part of the Keynote 522 trial that was published a little while ago that showed increased event-free survival with introducing neoadjuvant immunotherapy in addition to cytotoxic therapy. And then patients still undergo a modified radical mastectomy as they are considered to have, at presentation, high risk of nodal disease burden. And then adjuvant radiation is a planned part of their therapy as well.
And then do they get hormonal therapy as well?
Yeah, hormonal therapy if they are hormone receptor positive. And they tend to be recommended for more high risk duration for a patient to undergo more 7 to 10 years of endocrine therapy rather than just take 5 years for a lower risk patient. And then for a patient who's premenopausal, we may be thinking about aromatase inhibitor and ovarian function suppression, not just tamoxifen.
I guess I always think of inflammatory breast cancer as the worst kind of breast cancer you can have. And so is the follow-up of these patients any different?
So follow-up is similar in the sense that we are keeping a close eye on them, making sure they're having their dedicated breast imaging of the other side, following their exams. Systemic imaging is oftentimes a more routine aspect of their follow-up than an earlier breast cancer patient. So PET scans or CT bone scans, whatever was done at baseline, to keep on following these areas is critical as these patients are higher risk for not just local, regional, but distant recurrence.
Well, Jen, our time is almost up. And I, first of all, want to thank you for helping me out on a lot of these topics today.
No, thank you very much for the invitation. It's a pleasure.
You are one of our new CSAP authors. And while our process this time was not as face-to-face as it usually is, we looked at each other on the computer screen a lot as we developed our questions. But as a new author, do you have any comments for our listeners about the process by which CSAP develops the questions, what you think about it? The floor is yours.
I am incredibly impressed by all of your efforts and everyone with CSAP as well. The extent of vetting through questions and our answers, making sure we're really targeting this educational material to the appropriate audience, making sure the questions and answers are clear, they're engaging, they are relevant, they are up to date. I have been so impressed. I think CSAP should be the go-to CME for all surgeons. It really should be as well, because the extent and rigor of how academic the process is and how much we really pride ourselves on turning out key, accurate, cutting-edge information for surgeons to rely on in their practices is so absolutely essential, as not all of us can make it to society meetings every year or jump on webinars every year as well. I think this is a really important independent learning tool that hopefully will continue on for a long time.
Well, Jen, thank you as an author, because without the authors, CSAP would not be as you describe it, and it's your hard work that makes them good. I thank you for your time today, and I thank you, like I said, for helping me and the listeners review some of this material, and you have a nice evening.
Thank you. I hope it's helpful for all who are listening in.